So we are here today to discuss physician health and well-being, which is fortunately becoming more of a topic in the mainstream. It's something that all the hospitals and people who are not physicians are becoming aware of. And there are so many facets to what affects physicians' health and well-being, and also a lot of downstream effects of what happens when our health and well-being is affected. So, Dr. Thompson, what would you say are the things that are in the forefront of your mind about the biggest contributors to the problems that we're seeing as far as our well-being?
Well, if I can just start from a side trail.
Of course.
I have my screen up, you see it reflecting in my face. On October 23rd, JAMA produced an article improving the system to support clinician well-being and provide better patient care. Their emphasis being on the system, and they used a human relations and systems design engineer to generate the information that was used in this publication. And she really clearly differentiates between system elements that contribute to what they call clinician burnout, and then there are the human elements. And this particular article only focused on the system elements. It was very interesting in that she came to the conclusion that her investigations did not really produce any actionable items. And I'm not really sure what to do with that piece of information, because I don't think anybody would take issue with the idea that there is room for improvement in the system, in the workplace, for healthcare professionals of all varieties. She then diverted, and this is interesting, to established guidelines for workplace well-being that are targeted especially at healthcare corporations. Those guidelines didn't become visible to us, but it's interesting to me that while this medical industrial complex that John made reference to earlier has been being developed, I really wonder if any type of established system guidelines were ever made reference to. So I've kind of made this long entry into the conversation because of the time that I'm spending with this article and the emphasis on data to substantiate the claim that there's really a problem. So let's, from my point of view, the house is burning, although we cannot find data to validate our claims that I'll say the house is burning, and I don't mean to be hyperbolic in any way, although there is some, there's documented evidence of widespread prevalence of physician burnout, physicians quitting, early retirement, physician suicide rates are as high as they've ever been. And what is contributing to these things? It's that whole system that the systems engineer made reference to. It begins in part with the very poor implementation of very poor technological tools, the electronic health record. It's really an obstacle that's interposed between physicians, other healthcare clinicians, nurses, pharmacists, physical therapy, the whole 9 yards. In order to communicate with these people, we have to jump into this big, messy, laborious, frustrating tool to communicate in the end rather poorly with one another, when really what we need is not only patient-physician relationship, but physician-physician relationship and physician-clinician relationship. And Marnie, tell me when you want me to stop, because I can keep going and I don't want to occupy our whole time. Go ahead.
Well, no, you make a lot of good points. And I think, of course, in medicine, basically everything we do is evidence-based. We hang our hats on the science. And so it is difficult for us sometimes to explain to people outside of medicine what it is that we're seeing and how to fix it. And I think another huge issue that we're seeing is that we had a question about what percentage of our well-being is affected by the EHR. And what we're seeing is that physician autonomy is significantly compromised, and physicians are being directed to do things by people who do not practice medicine. And so they don't really know what it's like to be in the thick of it with patients. And so what are your thoughts on that? The loss of autonomy and how it affects everyone?
Yeah, I translate it into loss of personal freedom. You're right. These third parties, I'm going to add to electronic health record system something that all of us are very acutely aware of at this time, and that is administrative burden, which I describe as repeated acts of futility. So, you know, we have had robbed from us our ability to use our intellect. The time that I want to spend listening to a patient, asking a patient questions, doing a physical examination, reviewing laboratory data, reviewing literature to make decisions about how to treat a patient, I waste. One very quick, simple example that we can all relate to this morning. I was trying to discharge a patient. Very simple, clean case. Disruption of the electronic health record system. It ate up 30 minutes of my time before I told the IT person, who was doing the very best she could to help me, that I had other things. They just had to find another way to get this done because I was not going to sit with them. And that happens repeatedly throughout the day. So one of the things that this really wonderful systems engineer made reference to in her article, her JAMA article, and I am preparing a letter to the editor, which is why I'm so deeply into the article right now. She makes reference to systems that have positive outcomes, which we are readily visible, you know, right in front of us in the whole country. There are big, big organizations that get a lot done, that have happy employees. Oh, by the way, most physicians had no intention of becoming employees and have been compelled to become employees. That's a big root of the problem right there, is compulsion. Now, if you choose to be employed and you're happily employed, then that's a whole different paradigm. But for people who've been put out of business, and if you want to pay your mortgage and meet your family's needs, then you're going to have to become a data entry clerk for the man. That is really morally disturbing, big source of trouble for people. The system that has evolved, I do not think it has been designed with any forethought, is a system that has negative outcomes, frustration, anger, helplessness, futility. These emotions lead to negative outcomes for patient and physician. So I think that there is a lot of room for improvement as we begin to focus on the system rather than the clinician as the source of the problem for physician burnout.
Yes, absolutely. And that is, you know, what most of the studies looking at burnout say, is that we need to address it from a systems perspective, which is difficult because there are all these, you know, physician wellness programs and hospitals, and they say, you know, take care of yourself, do yoga, do whatever, do resilience training. But it's not addressing the system. And
it's a Band-Aid for the problem.
Yeah. And I think something that really strikes me is that if you ask almost any physician why they went into medicine, they'll tell you because it is so rewarding to be able to take care of patients and really, connect with people and feel like you're making a difference. And, getting through medical education, getting through residency, getting through all of that isn't for the faint of heart. There's 80-hour weeks, 80 hours plus for at least 5 years consecutively, lost time with family. There are so many unquantifiable sacrifices that can only be, it's only worth it if you are able to do what you set out to do, which is take care of patients. And so I'm interested to hear what you think about, the systems impeding our ability to actually take care of patients the way that they should be taken care of. And so the solution that results from that inability.
It is. And I think David and John gave us some good initial starting places with how to address that. You made reference to why physicians went into medicine. Very nice physician survey was done by the Physicians Foundation, and it documented by querying multiple thousands. I don't remember how many thousands, but it's a very well-respected physician survey from 2018. Why physicians went into medicine? Some went in for the money, and those people have left and should leave. Some went in for prestige, and prestige can be outward or inward. So if you went in for the prestige and that prestige is really important to you, I say march to your own drummer, look into your own heart, congratulate yourself for the good work that you do caring for your patients. You can be very, very proud of yourself and continue to morally survive in a very difficult environment. And then the third reason that physicians went into medicine is because of the personal gratification that they experience by caring for patients. And that can be preserved. You just really have to know who you are, what your values are. I spend a little bit of time every morning myself, doing my best to get off on the right foot and be sure that I meet my own higher needs by helping my patients. And when they turn around and say thank you to me, which they do in more ways than I can count, I feel very fortunate, then, I'm really deeply satisfied. Now, by the same token, it's a fight for the money. And I've never been one to fight for the money. It's not natural to me. But my intellectual property, my real property, my building, my computers, my staff are all being stolen from me by people with whom I have very little, if any, ability to negotiate for fair compensation for my intellectual property or the services, procedures I provide. And that's what really sticks in my craw, to put it nicely. I wrote the comment about a contract being a mandate. I have reviewed some contracts, I have negotiated some contracts, and our ability to defend ourselves against these big systems is really very limited. But although, like David and John said, we absolutely must. And if we don't, frankly, it's all over.
Yeah, you bring up a really good point, and that is the continually shrinking reimbursements. And I think something that is pretty significant is the public perception that physician salaries are the reason that our healthcare dollars are, so abundant. And really, we cost 8% of what this country spends on healthcare, 8%. But
it's a good example of a term that I don't like, fake news. Go ahead.
Yes, exactly. And one of my favorite infographics is the chart that shows, I don't know, 450% increase in administration and administrative dollars being spent, and the physician increase is like, you know.
I think it was 3,000.
Yes, you're right.
Yeah, it was 3,000% increase. And it was either the number of executives or reimbursement for executives. That I don't remember, but very easy to see where the healthcare dollars are going. A really interesting guy, entrepreneur by the name of, by the name of David Chase, who used to be COO for Microsoft, if I'm correct, who is now a really strong advocate for patients and physicians in the country. When he was working for Microsoft, at the top of Microsoft's budget was salaries. The second was benefits. So they said their benefit costs were very high, and they decided to investigate where that money was going. They followed, for ease of conversation, $2 into the healthcare benefits industry. And as soon as those $2 got through the door, one went north to the executives, another went south to what was an unacceptably low quality healthcare product for their employees. So they created their own healthcare plans. All of that to say, we do not have control over the media. Physician salaries are not the cost drivers. It is, you are correct. People in our society believe that it is, and they're continuing to be told that it is, which is in part why we must continue to do things like what we're doing right now, and that is get out and raise our voices and let the truth be known, as well as share this information with our patients, which I do on a daily basis. Some of them are clueless about what's happening, but very interested.
Mm-hmm. Absolutely. That is something I've noticed also, is that there are some who know and some who don't, but when they realize, it's shocking and horrifying to them. And I'd like to point out what Mr. Blatt said, 8% before overhead is taken out. So it's even less. But what do you think?
So that 8% represents physicians. I guess that's what, 8% of the national healthcare dollar or GDP goes to physician salaries. And then we have to pay our own staff and our mortgages and all of the equipment needed in our offices. And when all that's done, we get to take something home.
Right, exactly. I wonder, what do you think, and maybe I'm sure that from a surgeon's perspective, this will be really interesting to hear. What do you think about physicians being kind of outmoded or replaced with alternatives?
Are you talking about artificial intelligence or robotic surgery?
Intelligence, different types of professionals, which is great. I mean, a team-based care is, by the data, the most effective. But we're seeing physicians losing their jobs.
So a friend of mine, very aptly, Dr. Venu Julapalli, for any of you all out there who know him, says, evidence informed, but not evidence enslaved. So I think that AI is coming, but I also have reason to believe that it's farther away than we're being told it is. When it comes, my personal intention is to learn to use it and to stand on the shoulders of AI and be a better physician because of AI. My personal experience in the operating room is that I can see a role for robotics, but not independent robotics. Robotics have got to be overseen by human eyes and mind and hands. I believe that this medical industrial revolution is not unlike what happened to farmers in the early 20th century, when people who had family farms and had farms for generations, as some independent physicians have generations of family members who have been physicians in their practices, who only had a horse and a buggy, could not even fathom what was coming their way, but it came anyway. The future came, and the past does not come back. And I believe that the same is true for the healthcare industry, and that we are somewhat blindsided by what we've been overtaken by, and these bulldozers have already rolled. So people all over the world have survived revolutions in the past, and survivors are people who did what was necessary to adapt. They were honest with themselves about what the circumstances were, which I believe that we all must be. And I'm going to take a step back and go to that change of mind set that David made reference to earlier. And there are some book resources that I'd like to make reference to, Marnie, before we reach the end of this hour. People are saying, what resources, what tools are out there to help me make that intellectual and emotional paradigm shift to stop seeing myself as a frog in boiling water or victimized by my circumstances, and rather empowered to adapt to these changes and learn what I need to know, and then do what I need to do to both survive and thrive in a new and very rapidly changing environment. So now I'm going to circle back as somebody who has been a part of this revolution for the entirety of my career, and have technology being shoved down my throat, and I avoided the keyboard and the screen for 20 years until I realized I was 20 years behind the times. I think we'd better face the music, learn what we need to know, and take action to adapt, survive, and thrive.
Yes. I think that something that was pointed out in the previous panel, which I was really happy to hear, is that physicians together, we have so much power. And as soon as we realize that, we can really change the tides. So, these organizations like Practicing Physicians of America and, this whole Free2Care coalition, they're really making huge strides. And so it's happening, and
I can comment, if I may. So I got dragged into physician advocacy by a dear friend of mine who, let me not go down that trail. But in a way, if he didn't plant the seed for the physician movement, which I know he didn't do, he provided the impetus for the next big wave. And that was in 2014, 2015. We held a week-long conference in Keystone, Colorado. The summit at the summit, it was national grand rounds on the state of medicine in America. We had the AMA attending. We did make a splash. At that time, one of the things that I did to make that happen is I kind of went around the country and knocked on the doors of the existing physician advocacy groups at that time and said, hey, we're having a party, would you come? And the leadership came. We were really disappointed at physician response. But we had about 30 leaders from physician advocacy groups, very, very small groups from all around the country. So that's less than one physician advocacy group per state show up at the meeting, and it was really an historical event. So there's been a lot of water under the bridge since 2014, 2015. So here we are now at this virtual Free2Care conference where we can all get together and share our thoughts with each other without having to take time off from our businesses and get on a plane and get a hotel room and blah, blah, blah. So this is a wonderful opportunity. Thank you very much, Citizens Health. My observation is that this physician and citizen advocacy movement, what was a trickle in 2014, 2015, is a traffic jam now. So please be encouraged. We do feel helpless. It is very difficult. In Washington, a legislator said to me, "Don't you understand that the lobbyists are in our offices every day?" And I said, "Yes, I do. But you know that I, as a physician," I'm speaking to all physicians listening, "I took time off from my practice. I bought a ticket, a hotel room, and I'm meeting you face to face to tell you what matters to me. And if you have a moral dilemma with who you're going to listen to, me or a lobbyist, let's hear about it right now." And his response was, "That was a good one." So yes, we do need to go to Washington. We do need to know our legislators. We do need to have their phone numbers on speed dial. We do need to get to know their staffers. They need to know who we are, and we need to tell them what matters to us so that once they get to the floor, they can vote on our behalf. If we don't do that, we are victims of our own inaction. Now, you made reference to the possibility of physicians coming together across the country and raising our voices and wielding our pens, which we can do. And I'll tell you, we've been trying really, really hard. Bunch of really good people. There's a whole bunch of really good, very active, valuable physicians advocacy organizations out there. But as the leadership of these organizations have come together, to be very honest with you, we're struggling with some pride of possession, some history, some, interests in one subject or another that is have been. I'm going to use my own words here, and not to put words in anybody else's mouth. Are excuses for not coalescing into one unified voice. Where when we show up in Congress, and there are a lot of us in Congress right now, we got a few who have access to the White House. There are many of us who are lobbying at state levels. But unfortunately, when we go, we don't get to take with us the full number of physician advocates that are available because we haven't been able to set our differences aside and create a unified physician voice. That doesn't mean we're going to stop trying. We won't stop trying. We'll get there one day. One day we will arrive to Washington representing the largest number of physicians in the country, and an unnamed organization will be supplanted, and it will be by us, what Margaret Mead calls a small group of interested citizens that made a difference, and nothing else ever has. Thank you for giving me so much time.
That was very well said. And I think I love what you said too about that we're not going to stop trying. And that's the way that it's going to happen. So let's see. There's a question here. The projected physician shortage over the next decade, potentially 122,000 by 2032. So essentially a supply and demand question. Do you think that's going to happen? Do you think that we're going to see the supply and demand curve come up for us?
Yeah, a couple of things are happening. Number one, because of burnout, which we haven't really talked much about, and I think we ought to try to circle back to that for people who are interested. It is a number one issue of importance. Yes, we're going to see a shortage of physicians because people are quitting, they're retiring early, they're going into other businesses, or physicians are committing suicide. Physician suicide rate is the highest that it's ever been in history, and it is the highest of any profession in the country, and that is a tragedy. The other thing that's happening is that employed physicians, and we're right up on the evanescence of this problem, employed physicians are about to be replaced by employed mid-levels. We saw it in San Antonio recently where a bunch of anesthesiologists were released from their group and were replaced by mid-levels. So you have unemployed physicians floating around out there. And I don't mean to light the fire, but there are going to be many more before this is all over. So what's going to happen, in a nutshell, people are going to die one way or the other. There are going to be fewer physicians. And those who survive are those who are able to thrive within the system or adapt, survive, and thrive in a new, innovative healthcare system.
Yes, and I'm glad you brought up the physician suicide rate, because that is not something that is well known by the general public. and it's, between 2 and 4 times what it is in the general public. And, of course, there are a lot of theories about why that is, but absolutely, without question, a huge component of the reason, I believe, is whether you want to call it burnout, whether it's, there are a lot of terms being used for this phenomenon that we're seeing. And you're right, there is an exodus from medicine. And it is really scary because what happens when all the doctors are gone? I don't know.
I think it'll come full circle. I think that citizens, patients, and as John said earlier, we are all patients.
Mm-hmm.
You and I are going to land in a hospital one day, and an employee is going to arrive to the bedside to do a history and physical. And you and I may or may not have something to say about who that employee is or what their level of education may be. And we're going to be impacted at a visceral level. And we're going to say, this is unacceptable. And we're going to begin to innovate and create what it is that we want for ourselves, our families, and our community members. I think part of the pain that we're experiencing right now is the splitting of the American healthcare system into what may be, 2-tier system. And so that when we land in a hospital, or if an individual lands in a hospital, they may begin to have some choice about who it is that arrives to the bedside. And they may say, I have the privilege of choosing who comes to see me, and then we make that choice, in which case we're kind of reverting back to old-fashioned medicine, where that person has a relationship with a physician who they choose, which is really what we're fighting for right now. And if it happens to be that you are not in position to have that privilege, then you may kind of have to eat what you're served and be cared for by the individual who comes to care for you, who is functioning under the mandates of somebody who is not a healthcare professional. I want to circle back to this issue of mental health. It's called a mental health issue, and maybe it is and maybe it isn't. And I say it like that because I have learned recently how important sleep is for our mental health and our overall well-being. A fellow by the name of Matthew Walker has done some groundbreaking science, and he's written an international bestseller, Why We Sleep. If you haven't read it, it's worth the read. Sleep is third in line, following oxygen, water, and sleep. We'll die of sleep deprivation before we'll die of food deprivation. I think that what we're looking at is an epidemic of clinician exhaustion. And when we are mentally and physically exhausted in all of the ways that we are, which was the question that you asked me at the beginning of this presentation, why are we exhausted? But when we are, that's when things start to break down. And I said to you in a conversation that we had earlier this week, you take this group of exhausted individuals. There's an expression that the system engineer used in her JAMA article. She called it presenteeism. There's absenteeism, and then if you don't show up for some reason. Presenteeism means that physically you're there, but for any one of a number of reasons you cannot or are not functioning at your optimum capacity. Yeah, there's a lot of presenteeism out there right now because clinicians of all types are emotionally, intellectually, and physically exhausted, not only by the electronic health record system, the system as a whole, the administrative burden, the drive to focus on profit rather than patient care, and the list goes on.
Yes. Couldn't have said it better myself. I want to just bring up one other thing, and that is, I agree with you that it is most likely mostly not something to do with mental illness or whatever it is that you want to call it. This is, something that is happening to people who are, you know, overachievers. They have to be put in extraordinarily difficult situations, and withstanding immense pressure and functioning with exhaustion, like you said. And so then we see a constellation of things happen. But something else that we see that is very concerning is that, you know, when you're exposed to traumatic situations on a regular basis, I'm sure as a surgeon you understand that, you know, you can't control everything. Sometimes people don't do well, and you have to be affected by that. You know, if you're not affected by that,
you're not human.
You're not human. We all are human. But there is this perception that physicians aren't susceptible to being affected by those things. And I don't know if it's because people need to see physicians as somehow more able to control chance than other people, and or that they should be able to withstand anything and not be affected.
You know, I wonder, do you want to finish talking and I won't interrupt you? I'm notorious for it. Go ahead.
I was almost done, I promise. I was just going to say, you know, then it is such that physicians don't have access to mental health resources because there's licensure concerns and stuff. They're not supposed to be affected. So therefore they don't need care. So
back to the JAMA article. And the reason I keep connecting us with the JAMA article is because this systems engineer addressed that very issue, and these topics are coming up, and somehow we may be able to begin to cross the schism that there is between independent thinking physicians and a system that, at least for the foreseeable future, isn't going to go away. So what this systems engineer, one of the suggestions that she made was that the stigma and penalties for seeking any type of mental health assistance be removed from the record. Physicians who need psychological or psychiatric or supportive care or need to take time off to address real life issues, not have that be a part of their record and their licensing, credentialing, malpractice. So protection for our personal privacy as we do the things that we need to do to protect ourselves and take good care of ourselves as human beings. So it's really nice to hear the system at least acknowledge that that is a real human need that we have, and that we ought to be able to meet those needs in private without them being used to penalize us or hold us back from what we need to perform our profession. But I do want to take a moment to say to anybody who's listening and might be struggling with burnout, you must take care of yourself before you can take care of anybody else. And how to do that is a question. You know, I'd love to say, give me a call. I love to talk about it. I also know I don't have another minute in my day, but give me a call. I'd love to talk about it. Let me just say my cell phone and then I'll shut up. 830-608-4367. If you think you're in trouble, please call me. You're not alone, and we will help how we can.
Yes, thank you. Thank you so much for saying that. And I want to echo that. That is obviously a significant interest of mine. My organization, Mainstream Medicine, is part of the Free2Care coalition. And that is what we focus on, the well-being of people who cannot access care. So we are here, and I think we are at the time for questions. So here we go. Okay. To take burnout more seriously, perhaps it should be reclassified to a higher level in order to show the severity. Perhaps it should be a form of trauma. Earlier this year, the World Health Organization reclassified burnout as an illness.
That's absurd.
It's absurd. But to classify it as a form of trauma, I like that better. I mean, it's a result of trauma. I mean, there are so many different kinds of trauma. So the general definition isn't what everyone always thinks of. So
I think it's really important for us to at least consider not seeing ourselves as victims, and rather to see ourselves as individuals in a society that is going through change. And I'm not going to say it's not painful. I feel it. I've experienced it. But I think if we see ourselves as victims, we really get this thought in our heads that somebody else can do for us what we really have to do for ourselves. And that is make that mindset change that David made reference to, and understand that we are both valuable and powerful. David has asked more than once, but David, I can't see your comments or your questions. I'll try to pull them up. What are organizations doing? And I can only see part of it, maybe to help address physician burnout. Marnie, can you speak to that?
Oh, absolutely. So there are, a lot of efforts to improve the system. And we're seeing that a lot. Something that I had not seen is a resource for mental health care that is completely anonymous, off the grid, doesn't use the same sort of information storage systems that everything else does. And so that's why I got into this. But there are so many physicians who are advocating for changes that will help burnout. And I think it would be great to post a list of those organizations because there are so many resources.
Yeah, I agree with you. Are you not starting an organization of your own?
Oh, yes, we exist. We're a 501c3 nonprofit.
Tell us the name again, please, and your website.
Sure. It's Mainstream Medicine. That is mainstreammedicine.org. And we're actually starting a clinic third Thursday of every month. And it's pay what you can, so free if you want, or you can make a small donation. And this is for medical trainees, so medical students and residents, and first responders, because they are the populations that they run toward the fire, toward the trauma, and they don't always have the time or resources to get the help. So we want to make that easier, and so that's going to be in New York and Ohio.
Excuse me just a second. I have a book just within my reach, but I have to jump away from my camera, written by a very well-known national physician advocate named Pamela Weibel, and it speaks directly to the issue of the trauma that is experienced by physicians, residents, and medical students. Give me just a second. I'll be right back.
So,
can you see it? Human Rights Violations in Medicine, the A to Z Action Guide by Pamela Weibel. I really have to throw a shout out to her. I think she's probably done more than any one physician in the country to acknowledge, define, and provide us with resources to address this problem. So that, for me, that's going to be an important starting place, as well as Mainstream Medicine. And I'm sure I'm overlooking others out there who are addressing the issue. Please forgive me. I wish I had made a list of who you were so that I could read them off, but I'm sure that they can be searched and found pretty easily online.
Yeah, and what Dr. Weibel has done is absolutely bring attention to this massive crisis in our country, and that awareness is the first step to solving any problem. And I think that is something that we're kind of up against, is that people don't know what's happening. And even within the medical community, people don't necessarily want to even think, wow, I really need help here, because we're all so competitive. It's like, if you admit that you need something, it's like, but really we all need something. And
so, hey, we do. And you're just leading me to something that's so important. And let me write it down so I can stop interrupting you. Go ahead.
Please go ahead.
So it's very interesting. And I remember when this happened, it was before your time, Marnie. Physicians used to have a private gathering place where they could come together, let their hair down, be human being, discuss cases, life issues, and more importantly, experience fellowship. It was called the Physicians Lounge. And I remember in my career when executives and other clinicians just began to come into the doctor's lounge, and doctors around me were pitching a fit. And I thought, what's the big deal? But I'm not very social and I'm a hardcore introvert, so it didn't matter to me. And I like everybody, it didn't matter. But truth be known, I've heard more and more about it since that time, that physicians lost the place where they can come together and commune and have fellowship. I experienced it firsthand last weekend when the members of the board of directors of Practicing Physicians of America flew to Chicago and got together in a boardroom for a day for the first time. We've been doing all of our work with a telephone for the last 2 years. And to see each other's faces, to experience each other's emotions, to embrace each other, to share a meal together, to go for a walk together, was the most nourishing experience I have had in so many years. I couldn't believe it. And I'm a hardcore introvert. And I was convinced at that point that physicians need to have a gathering place where they can experience community, fellowship, be human, and not under the examining eyes of people who don't take on the levels of responsibility that we do, and that is holding other people's lives in our hands on a daily basis.
Yes. And I'm so glad you brought that up too, because that is one of the interventions that we see that is evidence-based and works, and that is peer support. And that's something that, you're right, we don't really have access to that. Even within our own circles of colleagues, it's how much do you feel comfortable saying about what's going on for you? But everyone is having those experiences that are, affecting you.
You don't know that. You think you're alone.
You do think you're alone.
And exactly. And so we've been siloed and isolated, and we've been threatened, and we are fearful. I have been there, yes, done that, waking up in the middle of the night, shaking, sweating, wondering, knowing that things were going to change, and believing that I was the only one experiencing that.
Right. And I think every one of us has that experience. It's lonely, and there's a lot of pressure, and we just need to come together. And I promise whoever's listening, you are not alone. You're not. And that is actually something that mainstream medicine is doing. And it's going to be virtual support groups, which are conducted like this, actually, but in kind of a different setting. And it can be anonymous, and it's screened by me. Everyone is screened by me to make sure that everyone gets into the correct group, because I think that is something that's really valuable, and it's something that isn't happening. And so we're in alpha testing mode right now, so that should be announced pretty soon. So,
well, thank you for what you're doing, David. We need to get together in person, physicians as a whole, and I know you know that. And so John, this is a wonderful opportunity. Thank you for providing it for us. And when we get together, I would like us not see session after session after session where we are, what I do want to see is the opportunity for fellowship, community, rest, relaxation. I think if you take this group of fatigued individuals, you give them some rest. I got off on my sleep thing earlier, which is very, very important, by the way, to mental and physical health. You give this group of people some rest, some nourishment, some fellowship. I'm thinking 2 or 3 days, you are going to take what I call a herd of cats and transform it into a pride of lions. We're going to understand our value. We're going to understand our power. We're going to start using our keyboards and our pens and our stethoscopes to interface with these profiteering executives and begin to move the needle and let them know that we command the practice of medicine and not them. But I also think that we're going to be a comparatively smaller group than we have been before, but we're also going to be a group with minds and spines. The ones without minds and spines are going somewhere else.
Yes. I guess, so we're almost out of time, but I just want to also point out that physicians and patients we're all out for the same goal, and that is amazing patient care. And so really all these intermediaries who affect the relationship between the physician and the patient, we don't need them. That's the beauty of direct care. And of course there are hospital-based specialties, but I think eventually we'll be able to make sure that's more direct too. And also the struggle of the primary care physician, I think is another big thing that we need to address, because man, they are not appreciated enough. I appreciate you. There's so much good that can be done, and I look forward to seeing that happen. So I think we'll end there. Yes, I agree with you. We don't need no stinking intermediaries.
So guys, if we don't have another couple of minutes and say so, I'm a surgeon and a breast cancer surgeon, and I need a lot of support for what I do. And I'm frankly dependent upon the system. And when a person has a diagnosis of breast cancer, any other type of cancer or catastrophic illness, they need their insurance plan. And so, we don't need to go off on how insurance plans have gone awry. But I have to learn to get along with the system, which for the foreseeable future is going to continue to be here. I've got to learn to do what David said, understand my value and understand my power and be a meaningful contributor. And what I want to do is, again, stand on the shoulders of what those people, those tools and services that the system provides to patients for what they need to treat their illnesses, rather than feel like I'm carrying the system on my own shoulders. But that's an intellectual, emotional, spiritual, professional paradigm shift that takes a lot of work. Hey, can I just quickly show people some books that have been very helpful? Is that okay?
Yeah, for sure, too. And
Marnie?
I think, am I muted? Oh, I'm sorry, Dr. Judy. Hey,
no, you're good.
There's a couple questions that I'm not
Go
sure
ahead.
got addressed there. Do you see the Q&A option? I mean, I think we've been reading that.
Yeah,
There's a couple down there by Dr.
Oh, okay.
And also the student shortage. I think that's something to be addressed, because you're seeing a lot of medical school students choosing to not continue just because they're already burnt out. And that's something that really needs to be addressed.
It really does. And GMA funding needs to be expanded. Absolutely. That was frozen in what, 1997?
So when I went to medical school in 1986, I was bombarded with, why are you in medical school? It's not worth it. So it depends on what your values are.
Yes.
And it depends on what matters to you. Now, I think one of the biggest problems that medical students are facing right now, and it's not something that I've delved into, is the mismatch between the debt that is generated getting through school and what they can anticipate to earn. That's a financial non-starter. I think that needs to be addressed. I think that people who love caring for people and people who think that that's the most wonderful job in the world, and that to me that translates into prestige, need to come on, but need to understand that this is a very tough place. But if you're doing it for the right reason, I do think that you'll be okay, but you got to look in your own heart and look in your own mind and be clear with yourself about why you're doing what you're doing, and can you really afford to do what you're doing? And if you can't, then maybe you need to revisit that question or re-examine your resources so that you can get through it, so that you're not compelled to do something that you don't want to do just to pay the bills. None of us want to go through all of that, all of this to be in that situation.
No way. And I would say I agree with you up and down. Like, that's if a person is considering going into medicine for financial security or financial reasons, bad idea, really bad idea. But if you're doing it for the patient care, that's what's going to get you through it. Otherwise, it's untenable these days.
Another question, look how physicians came together when a malpractice crisis hit California in the 1970s and McGrath came about. Why not arrange a trip to Washington in the spring on the same day, accost our congressman, and take no prisoners? Our livelihood is at stake. That's Ernest Sussman. Thank you very much, Ernest. Well said. And we have done that several times. I suspect that we will continue to do that. If you will become a member of Practicing Physicians of America, which there's no expense to you, again, contributions needed and appreciated. We will keep you informed when we're meeting. We've held some very, very nice meetings in the Library of Congress where Marion Mass, who has entree into the halls of Congress like nothing any one of the rest of us have seen, and she will teach you what you need to know to prepare yourself to meet and have meaningful impact with your representative. But we've done it before, we'll do it again, and thank you for that comment. Marnie, is it legal for potential new employers to ask about prior mental health treatment?
Well, in some states, that is a question on the licensing applications. In other states, it is not. So we're moving toward the question, do you have anything that is currently impairing your ability to practice medicine? And elsewhere, it's directly adjacent to the criminality section of the application. So that is something that we need to fix. And physicians' licenses are in jeopardy sometimes. And even if it's not an immediate concern, it's always a grain of doubt. And that's scary. And so then people don't get the help that they need, and that is also scary. So, well, it is 1:59, so I think we should wrap up, but thank you all so much. Thank you, Dr. Thompson. It was a pleasure.
Thank you, Marnie.
Yes, thank you both, and thank you all for all the questions, and that was very informative. And Dr. Judy, you got me fired up about coming together.
Yay!
You have my support, as always, and that's what it's going to take, is everybody coming together and united to make some change. All right, well, thank you all, and now I will stop the video for you all and bring on our next panel.